Chest pain is extremely common and is one of the most common calls you're going to write. There are three causes that are worse than the rest, and we're going to talk about them today. The first one is going to be your MI, myocardial infarction, heart attack, STEMI, whatever you want to call it. Think classic cardiac chest pain. It's going to be a dull, deep pressure, heaviness, squeezing in the chest, might radiate to the arm, might radiate to the jaw. They're usually going to be pale, sweaty, and anxious. That's going to be a visceral pain response. Okay, visceral pain, it tends to be stemming from an organ. It is usually poorly localized, is usually diffuse. For these patients, you're going to want to get a 12 lead early. You're going to want 324 milligrams of aspirin, nitro, if BP allows and your protocols allow, and get them to a PCI capable center fast. Don't overthink it. If it looks like cardiac chest pain, it probably is cardiac chest pain, despite what the monitor is telling you. Number two is going to be a thoracic aortic dissection. So picture this as your aorta. In a aortic dissection, the inner layers of the artery are basically ripping from the inside out, right? This patient is going to present with a very severe tearing-like pain, often deep in their chest or between their shoulder blades. This is a surgical emergency. Treat supportively, treat pain, and transport rapidly to a definitive hospital that can treat surgically. Aortic dissection patients can have unequal pulses. Feel both of their radial pulses simultaneously, see if they feel equal. Also get a blood pressure on both arms, see if there's more than a 20-point variation. If all your findings are normal, that does not necessarily exclude aortic dissection, but if one of your pulses is unequal, if you have more than the 20-point variation, that is your cue. Get going, get this patient to a hospital rapidly. Number three is going to be a pulmonary embolism. Think of your immobilized patients, recent surgery, bedbound, severe infections. Anything that can immobilize a patient can potentially cause a DVT. DVT, travel to the lung, cause a pulmonary embolism. Another group to worry about is women on oral contraceptives. Some contraceptives have been shown to increase the risk of DVTs and therefore pulmonary embolisms. PE patients are often going to present with sudden onset shortness of breath, tachycardia, sometimes sharp stabbing chest pain, sometimes pleuritic chest pain. They're going to have clear lung sounds and a low O2 saturation. That's your giveaway right there. Your lungs sound clear. You should have a good O2 saturation, but you don't. That is your red flag for a PE. Remember Verco's triad for causes of PE. PE patient, you're going to want to treat supportively, high flow oxygen, rapid transport to a hospital. Thrombolytics or thrombectomy is the only treatment for a PE. Cannot really do anything on the pre-hospital level other than treat them supportively. When in doubt, think of these three first: MI, aortic dissection, and pulmonary embolism. Always rule out the killers before you write something off as chest wall pain or anxiety. Thank you for watching.